Good morning. Thanks for the opportunity to talk about BTK inhibitors today. And I know that you had some talks yesterday on the CLL, SLL, and also on Waldenstrom. So I will try and go with the other lymphomas. So in terms of my plan, I'm going to spend a few minutes on background. And then in terms of the B-cell malignancies, I'm going to talk a little bit about follicular lymphoma and marginal zone lymphoma, which were not covered in yesterday's. And then diffuse large B-cell lymphoma and lymphoplasmacytic, this was covered. But again, if some of you weren't here yesterday, just a couple of slides on that. Then I am not going to cover mantle cell because Peter Martin will be talking about that later this afternoon. And then SLL, CLL was covered extensively yesterday by Dr. Bird. And then I put an asterisk next to the approved indications for Ibrutinib, and all of the other are not approved indications. So in terms of the mechanism, I know you guys know this slide, but I think I just want to remind folks that the BTK inhibitors are thought to act by blocking the downstream B-cell receptor signaling pathways and preventing B-cell proliferation, specifically blocking BTK. And then I think it's also important to know that with Ibrutinib at least, that it also interacts with other kinases besides BTK, including TEC, EGFR, ITK, and JAK2, which may account for some of the toxicities. So just want to put one slide up about the common side effect profile, because this will apply to all of the lymphomas that we're going to speak about. So I would say my conclusion about the side effects is it is generally well tolerated. However, I'm sure many of you know there have been a lot of cardiovascular side effects, primarily hypertension and atrial fibrillation, which probably occurs in somewhere between 5 and 15% of patients. And they do have some prognostic models in terms of patients with underlying cardiovascular disease. Older patients are at higher risk. There is a significant increased risk of bruising and a small but significant risk of serious bleeding, so need to use a lot of caution with the anticoagulation. And then neutropenia and thrombocytopenia. And interestingly, I think if you follow patients for quite a while, you start seeing this more commonly as they are on the therapy longer. And then something that we run into a lot of trouble with in terms of quality of life are fairly frequent myalgias and arthralgias, which tend to be transient and migratory, sometimes lower extremity edema. Although diarrhea is in the package insert as one of the most common side effects, I must say in my experience that's pretty uncommon. And then the risk of serious infections is low, but it is there and should be remembered, both invasive bacterial and fungal infections, specifically invasive aspergillosis. And most of these cases have been reported in combination studies, but not all. And it sort of all started with this very high rate of aspergillosis and CNS lymphoma study that was, again, multi-drug regimen. And the aspergillosis occurs usually very early, usually within the first 3 months, but almost always within the first 6 months. So in terms of trying to address some of the toxicities, there's a lot of work on trying to develop more selective, irreversible BTK inhibitors. And I just put 3 of them on the slide here. I bolded acalabrutinib because that's the only other approved BTK inhibitor, and that's approved for relapsed mantle cell lymphoma. And then there are more besides these 3 that are sort of in earlier development. And the hope with the more selective BTK inhibitors is that it will have a more favorable toxicity profile. So if there's less inhibition of EGFR, less diarrhea, less rash, decreased inhibition of ITK, which is a critical modulator of NK cell function, perhaps would be resulting in less infection, decreased inhibition of TEC kinase, which is expressed on platelets, so maybe less, and is required for platelet aggregation, so perhaps less bleeding. It's also expressed on heart tissue, so hopefully lower risk of atrial fibrillation. which has actually been seen with all three of these agents, very low risk of AFib, and also perhaps a decreased effect on the immunoglobulin levels, which you do see with ibrutinib, but has not been seen with the more selective BTK inhibitors. In terms of the common side effects of the more selective inhibitors, it's a little bit different toxicity profile than with ibrutinib, and I specifically just put the most common side effects with acalabrutinib. So headache, which we don't really see with ibrutinib, occurs in almost half of patients, somewhere between 40 and 50%, occurs early and usually resolves. So unless it's very severe, is usually not a reason to discontinue treatment. Interestingly, weight gain, and then really have not seen AFib and very low incidence of grade 3 or 4 bleeding. So the trial that we really need to see, which will be very helpful, is the phase 3 trial that's still pending. It completed accrual, I think, a couple of years ago now, of acalabrutinib versus ibrutinib as frontline treatment in CLL. So will be key to see the not only the difference in toxicity profile, but also to confirm that they are at least equally efficacious. So we're going to start with the response rates of BTK inhibitors in relapsed and refractory follicular lymphoma. So there's been 2 phase 2 studies of ibrutinib. One was a multi-center phase 2 consortium study, and the overall response rate in 40 patients was 37% with a CR rate of 12%. And to be eligible for this, you only had to have failed 1 prior line of therapy. So we did have patients on this study who were rituximab sensitive, and they had a higher response rate of about 53% versus 17% in the rituximab refractory patients. There was also a multi-center study that was run by Pharmacyclics called the DAWN study, which included 110 patients. And to be eligible for this study, you had to be refractory to both alkylators and rituximab, meaning have failed both of those lines of therapy within 6 months. And the overall response rate really quite low, 20%, but very similar to the rituximab refractory in the P2C study, and a CR rate of 10%. So there's your 20.9% actually. And then there was also a multi-center study of zanubrutinib, one of the more selective BTK inhibitors, included only 17 patients with follicular lymphoma, 41% response rate, and these patients did not have to be refractory. So I think pretty consistent over those 3 studies. And then here's the PFS and overall survival curve for the phase 2 consortium study. So unfortunately, as opposed to the CLL studies where you see the ibrutinib PFS curve dropping extremely slowly, this one drops pretty quickly with a median PFS of 14 months and a 2-year PFS of 20%. So again, really even in the responders, not much durability there. And the DAWN study the same way. So here's the PFS curve with a 30-month PFS of 11%. And again, these were the refractory patients. So one thing that we did do in the P2C study was we had 31 patients who had new biopsies at the time of study entry, and did whole exome sequencing on these patients, and interestingly found something that had been reported previously in a small set of DLBCL patients, which that patients who had a CARD11 mutation had a much worse PFS, and in fact there were 0 of 5 responders in the CARD11 mutated group, as opposed to the CARD11 wild type, where 50% of patients responded. There were also additional mutations which did predict for improved PFS. So then what about ibrutinib in relapsed and refractory marginal zone lymphoma? So there's only been 1 published study using ibrutinib in marginal zone lymphoma, and had 60 patients in it, but was actually a registration trial for ibrutinib in this indication, and is actually an FDA approved indication. So the overall response rate was 48% in all comers with a median progression-free survival of 14 months. And interestingly, if you look at the details of the paper that, which I had not done very carefully until last night, so that the majority of patients actually had extranodal marginal zone lymphoma. Some of them had both nodal and extranodal, but at least half of them had at least a site of extranodal marginal zone lymphoma. 14 patients had splenic marginal zone lymphoma, and only 17 patients had nodal marginal zone lymphoma. And if you look at the response rates, pretty similar, although the nodal marginal zone lymphoma had the lowest response rate and also had the shortest median duration of response. And so I think that's actually where most of us are using Ibrutinib. So it's important to remember that when you're talking to the patients and treating them with this, that the expectation is about a 40% response rate with less than a 12-month PFS for those patients. And then how about Ibrutinib and diffuse large B-cell lymphoma? I think Dr. Yunus might be talking a little bit about this later this afternoon as well. So this is a study from Wyndham Wilson. It's actually a multi-center study of Ibrutinib and diffuse large B-cell lymphoma that initiated out of the NCI. 80 patients with a 25% overall response rate, but this unexpected or actually expected finding, if you think about the mechanism, that had a much better response rate in the ABC subtype than in the GCB, so only 1 of 20 GCB patients responded as opposed to 37% of the ABC patients with a 16% CR rate. But you can see from this PFS curve that it is not very durable, so the blue curve is the ABC subtype, and that you can see by a year almost all the patients had relapsed. And then this group also did whole exome sequencing and had some pretty interesting findings in terms of subsets of patients who respond within the ABC subtype. So 4 of 5 patients who had both a CD79B mutation and an MYD88 mutation responded. So again, this is a small subset of patients, but I think just speaks to the point that we may be able to figure out the patients who would respond. And then this is one of the more selective BTK inhibitors, and this again was a study that had several subtypes of lymphoma in it, but I just put it up because it also had 35 DLBCL patients who had relapsed and refractory DLBCL and had a PFS curve that looked very similar to Dr. Wilson's curve with Ibrutinib. So then this was just recently published in Blood by the Memorial Sloan Kettering Group, which was a phase 1 study of R-ICE plus Ibrutinib in relapsed and refractory DLBCL, had only 21 patients, 20 of whom were evaluable for response, and they actually escalated the dose of Ibrutinib up to 840 milligrams a day and did not have any DLTs. The overall response rate was 90% with a CR rate of 55%, and in the non-GCB subtype it was 100%, and I think this was determined by the Hans criteria. And I did forget to mention that in Dr. Wilson's study that the ABC was actually determined by gene expression profiling. And there will be a phase 2 study that will be activated soon of this combination. I think maybe just a handful of institutions will be participating in relatively small, I think 50 patients. But it does look encouraging, especially in these non-GCB patients with a very high CR rate. And then this phase 3 study of R-CHOP plus Ibrutinib versus R-CHOP in untreated non-GCB. So based on Dr. Wilson's preliminary results showing a high response rate in the non-GCB, they did a very large international trial comparing R-CHOP to Ibrutinib plus R-CHOP, specifically in non-GCB that was determined by the Hans criteria, and it was over 800 patients, and had a recent press release. We have not seen the results of the study, but the press release said that the phase 3 trial did not meet the primary endpoint of EFS in the patients with non-GCB DLBCL, but had a caveat saying that clinically meaningful improvements were observed in a patient subpopulation. And so I guess we'll just have to wait and see those results in terms of whether there may be a subset of patients who respond. So a little bit disappointing. I think this is where we keep finding ourselves with upfront DLBCL, is adding drug X to R-CHOP. And unfortunately, this is just one of a series that have not shown a benefit there. So I think, again, we probably need a better way to find the patients who would benefit from Ibrutinib. Just taking the Hans criteria, non-GCB did not do the trick. And then I didn't put a slide on here, but would just mention the current Alliance intergroup study of Ibrutinib in patients who have relapsed DLBCL that are undergoing a stem cell transplant. So they actually get Ibrutinib as part of the preparative regimen and then get Ibrutinib maintenance after the transplant. So if any of you have that trial open, we'd be very enthusiastic about additional accruals. And so then how about Waldenstrom's macroglobulinemia? So again, I think there was a specific talk on this yesterday in the CLL session, but just for those of you who were not here, the overall response rate to Ibrutinib in this study of relapsed refractory lymphoplasmacytic lymphoma was 100% with a major response rate of 91%. Lower response rate in patients who have a CXCR4 mutation. And in terms of durability, I'm not sure they gave a 2-year PFS in the paper, but if you look at it there, it looks like it's about 70%. And then this was just recently published for Waldenstrom's, which is Ibrutinib and Rituximab in frontline and relapsed and refractory Waldenstrom's. So it was a study that included about half of the patients who had never been treated before, and half of the patients had relapsed or refractory Waldenstrom's. And it was comparing Ibrutinib and Rituximab to placebo plus Rituximab, so basically single agent Rituximab versus Ibrutinib Rituximab. And I think, not shockingly, the Ibrutinib Rituximab was better. So I think the study that we probably need to see is Ibrutinib alone versus Ibrutinib Rituximab, because that combination has also been studied in CLL, and at least in CLL, it does not appear that there's a benefit to giving Rituximab in combination with Ibrutinib, and so that may be the same thing in Waldenstrom's, and I worry a little bit about the increased risk of infection when you're giving both of those drugs together. So again, before I jumped on this bandwagon, I would like to see whether adding Rituximab to single-agent Ibrutinib really improves the response rates or PFS. And then I also think that it would be important to compare this combination, or Ibrutinib alone, to BR, again, because of this fixed duration of therapy, that the results with BR and lymphoplasmacytic lymphoma look very good in terms of durability. So in terms of conclusions for BTK inhibitors and B-cell lymphoma, in terms of the opportunities, I think, as we've talked about, it has a unique mechanism of action. I didn't go too much into the combination studies, of which there are many of them in CLL, but it does look like it, for the most part, plays well with other combinations, so it can be added to RICE, can be added to R-CHOP. There's a study with R-DAP is being combined in mantle cell and CLL with venetoclax. So I think that may be where we're going to be going with this is combinations potentially. And I think what we really need to do with the combinations is see if there's a way that we can make this a fixed duration therapy, meaning that doesn't go on forever, which would be great for the patient for many reasons. And then I think, again, lots of opportunities potentially with these more selective inhibitors, and it'll be interesting to see the results of the phase 3 study in CLL. And that I would say, again, very well tolerated overall. In terms of the challenges, I would say the number one challenge is probably cost, which for even approved indications is sometimes difficult for patients, that they get the drug approved and then find out they have a $5,000 copay per month for several months before that kind of goes off. So again, I think that has been an issue, even in approved indications. And I think this indefinite treatment is also an issue, not only from a cost perspective, but also some of these side effects that tend to be worse as you're on the drug for a longer period of time. And then acquired resistance is obviously a challenge, and then the sort of unique toxicities of AFib and bleeding, which may be addressed with the more selective BTK inhibitors. And then I think what we really need for the lymphomas that we talked about briefly that are less responsive than CLL, SLL, and mantle cell lymphoma would be predictive markers for these less responsive lymphomas. So if we can figure out which patients with follicular lymphoma would respond, it would be a useful drug, but when you know that the response rate is going to be 20 to 40%, if you take all comers, then less interesting. Very good, thanks.